Hello, my name is Paola Cinque and I'm a clinician at the San Raffaele Infectious Disease Institute in Milano, in Italy. This lecture will be comprised of two sections, and I would like to start this talk on the HIV-associated immune reconstitution inflammatory syndrome, or IRIS, with a definition for this syndrome. And this definition includes three principal components. First, being HIV positive. Second, experiencing an immune reconstitution, and this is almost always subsequent to the introduction of an effective antiretroviral treatment with a decreased HIV RNA level from baseline and usually, but not necessarily, an increased CD4 cell counts from baseline. Third, for having IRIS, we also need the presence of clinical symptoms or signs or findings consistent with inflammation. And importantly, the clinical course should not be consistent with the expected course of a previously diagnosed opportunistic infection or of a newly diagnosed opportunistic infection or with drug toxicity. The key part and also the characterizing component of IRIS is inflammation. Inflammation is directed against infectious or non-infectious antigen with a resulting inflammatory reaction that may be very, very deleterious. And the inflammatory reaction in IRIS can be sustained by a number of different types of antigens. Most commonly, we have an underlying opportunistic infection, such as in the case of infections caused by mycobacteria, cryptococcus, pneumocystis, leishmania, or by viruses such as hepatitis B and C viruses, cytomegaloviruses, varicella zoster virus, or herpes simplex viruses, or JC virus, like in the case of PML, that is progressive multifocal leukoencephalopathy. The inflammatory reaction of IRIS can also be observed in the context of tumors associated with infections, such as warts caused by the human papillomavirus, or HPV, Kaposi sarcoma, or Castleman's disease, both associated with HHV-8 infection, or non-Hodgkin lymphoma, which we know it is associated with Epstein-Barr virus infection in most of the cases of HIV-associated lymphoma. Also, it's interesting to observe that IRIS might present in the form of an autoimmune disease such as lupus, rheumatoid arthritis, polymyositis, alopecia, or allergic reactions, for instance, towards tattoos or insect bites. Importantly, the infection may be subclinical, which means with a relatively low microbial burden. And it is also possible that in some cases, IRIS is triggered by residual microbial antigens in the absence of microbial replication. So in the case of autoimmune diseases, it's likely that inflammatory reaction is directed towards tissue antigens, which may become exposed because of tissue damage or mechanisms of molecular mimicry secondary to opportunistic infections. It's interesting to note that pathologically, the inflammatory infiltrate in tissue may vary according to the triggering infection. So, with mycobacteria, fungi, or protozoa, we will have a prevalent granulomatous reaction. In contrast with viruses, the infiltrate will mainly consist of CD8 positive lymphocytes. Clinically, we can recognize two types of IRIS, unmasking or paradoxical. Unmasking IRIS occurs in patients without an ongoing opportunistic infection or other apparent underlying conditions. In these cases, the start of ART will unmask a subclinical condition through the inflammatory reaction against silent antigens. As you can see in the far left bar of this figure, which shows that most cases occur within 3 months of initiating ART. In paradoxical IRIS, we will have an enhanced or paradoxical response against a non-opportunistic infection, worsening the course of this underlying infection. Here is an example of unmasking IRIS associated with an autoimmune condition. This patient developed a severe skin depigmentation and alopecia 20 weeks after starting ART. At the time of IRIS, his CD4 positive cells had increased from 43 to 203 cells per microliter, and viral load had decreased from 12,000 to undetectable. And this is another example of paradoxical iris in the form of post-Kala-Azar dermal leishmaniasis, or PKDL. This was the case of a woman with a previous history of visceral leishmaniasis who developed iris 7 weeks from start of ART. At that time, her CD4 positive lymphocytes had increased from 98 to 390 cells per microliter, and the viral load had decreased from 480,000 to 760 copies per ml. PKDL recovered within a few months following a switch from miltefosine to amphotericin B as anti-leishmanial treatment and continuation of ART. But what's behind these forms? What are the mechanisms involved in the pathogenesis of the different forms of iris? And what are the risk factors for developing iris? So one key factor in the development of iris seems to be an excess of immune response or of a dysregulated response. For instance, in patients with mycobacterial iris, shown here on the left, the specific CD4 T-cell response against Mycobacterium tuberculosis at the time of iris was increased, illustrated by the rising red lines compared to patients who did not develop iris, as shown here in the figure on the right, where the values are more stable. Here is a simple model for immunopathogenesis of iris. Advanced HIV infection is characterized by severe immunodeficiency and associated with the onset of opportunistic infection. With the start of ART, there is an expansion of memory T cells which are specifically directed towards the opportunistic pathogens. At the same time, there might also be a delayed recovery of the number and/or function of regulatory T cells. So, in the end, a protective but disproportionate cell-mediated immune response driven by pathogen-derived antigens may lead to tissue damage. And what about the risk factor for iris? There are some general variables that have been associated with iris development. These include the CD4 cell counts and HIV viral load at the time of starting ART, as well as the changes of CD4 cells and viral load induced by ART itself. There might also be a role for host genetic susceptibility, and some studies have shown that patients who develop iris are more frequently of black race and have a higher frequency of some alleles such as HLA-A2, HLA-B44 or DR4, and of certain polymorphisms in the genes encoding for cytokines such as IL-12, IL-6 and TNF-alpha. Also, paradoxical iris seems to be more frequent and severe in patients with more severe opportunistic infections, in association with higher antigen burden. And what about iris frequency? According to a recent meta-analysis which pulled together data from over 13,000 patients from 44 cohorts, we can see here in the middle column of this figure that it seems that iris occurs in approximately 16% of cases with tuberculosis, in 20% of cases of cryptococcosis, in as high as in 40% of patients with CMV retinitis, 6% of cases of Kaposi sarcoma, and in 17% of cases with progressive multifocal leukoencephalopathy. So, overall, the frequency of iris among patients with opportunistic infection who start ART seem to be of about 15 to 20%. So we have reached now the end of part 1 of this lecture. In part 2, we will discuss prevention and treatment of iris.